Pleasure to be here. I think it's the fourth year in a row. Thank you, Dr. Sharma. Dr. Kading is a really hard act to follow, so I'll try my best. We do a lot of CT and MRA for peripheral vascular disease. We work very closely with the interventional group here, as well as Dr. Kading and Dr. Olin. I have no disclosures. I'm just going to go quickly. We know that PAD is the most common vascular disease following that of coronary atherosclerosis and stroke. And as of 2010, and we don't have a more recent census, over 22 million people worldwide suffer from PAD. So if you're going into this field for your profession, you will not have a lack of patients. It encompasses about 14% of the world population. I'm going to be focusing mostly on what I do every day is CTA, and here at Mount Sinai, we don't only do coronary CTA, we do everything, what I say, from the earlobes to the toes, and everything in between. And we do that both for CT as well as MRI. And both can complement each other very well, because obviously no, MRI does not have radiological exposure, so you could alternate the years or alternate the studies if you want to minimize the amount of radiation exposure. Dr. Kading did an amazing job. I'll skip over her expertise, but I'm going to be focusing again on CT and MR. So why is CT so great? Well, obviously with contrast, we could see calcification of the aortic wall, plaque, wall thickening, wall enhancement if there's a vasculitis. We have a lot of cases from the vascular group. We could see intramural hematoma and so forth. And then we could also use CT for treatment planning for interventional procedures, because we could tell exactly where the level of disease is, the amount of calcified or non-calcified plaque, the length of that stenosis, whether there's an occlusion or subtotal occlusion, and we could give a lot of information about the vessels prior to procedure. And we hope to guide you before going into the cath lab. Basically, we want to make sure that when doing a CTA, we avoid and make a crucial diagnosis of acute limb ischemia. I bring up this slide because right now there are probably two, and we're probably going to get a third way of doing CT, particularly that right now is digital subtraction angiography. That's what most hospitals use, most radiology departments. And this is great for pre-treatment evaluation of arterial stenosis in patients with PAD. But one should look at something called dual energy technique. And it's really more advanced X-ray attenuation using different photon energies. But by simultaneously acquiring a data set at high and low tube voltages, and I know this is a little technical, but it can do amazing post-processing where we could remove some material, particularly calcification surrounding tissue, particularly that of bones, and really look at the intraluminal plaques and give you a true CT luminogram that's non-invasive. This permits a more accurate three-dimensional maximum intensity projection. You might hear us say that, and that is better than DSA. So if we look closely at this publication, just comparing the two, and I'll go quickly, this is a 69-year-old male with peripheral arterial occlusive disease. And if you look at the image A, you can see that's a DSA, and with the arrow, there's an area of stenosis. But when using dual energy CT, not only do we actually pinpoint where that area of stenosis is, but we could actually remove the calcification and indeed do a transverse section of the vessel and do this beautiful MPR, curved MPR, here in the far right, in the F image. And I could actually give you the level of the lesion, the cross-section of the lesion in diameter, and remove the blooming artifact of calcification. We do three-dimensional or 3D recons with maximum intensity projections, and you'll see this sometimes if you come down to our lab. This is where I call the earlobes to the toes. And what's great about this is that we could see the entire aortic tree all the way down to the tibial arteries and posterior tibial arteries, DP as well. So So why CTA for pre-intervention? Again, it just gives you a wonderful anatomy, pinpoints where the stenosis is, and you can see in this particular case, the left common femoral artery has moderate stenosis, but there's significant severe subtotal occlusion of the ostia of the left profunda with diffuse disease in the SFA. This is post-intervention CT, demonstrating an interval stenting of the entire length of the left SFA. The stent you can see here is patent, but there is a stable subtotal occlusion, again, of that proximal left profunda. We measured it for about 6 centimeters. I won't go into too much detail because we all are very well versed on types of aortic dissection, but a lot of our cases, in addition to Dr. Sharma and his group with the interventionalist, is working with our chief surgeon, who is also a vascular surgeon, Dr. Michael Marin, and we do about 30 to 40 CTs of his patients a day, particularly for abdominal aortic aneurysm, as well as type B thoracic aneurysms. Really quickly, I don't want to belabor, but we all know this. We could look very well in detail using CT for intramural hematoma, penetrating atherosclerotic aortic ulcer, as well as thoracic aortic rupture, which obviously we try to avoid. Again, we could very detailed see the intima media, the false and true lumens. The aortic dissection type B usually is most common in males over 65. We could look at type B dissections, and if you look at duration or chronological order, chronic seems to be greater than 3 months. But what you really want to avoid and really want to have a really good cardiologist or radiologist who looks at these every day, and we do, like, again, about 30 or 40 a week, excluding Dr. Katie and Dr. Olin's studies. You really want to make sure that there is obviously no aortic rupture, but also with the patient's uncontrolled hypertension, but particularly malperfusion of the viscera and that of the lower extremity. Malperfusion syndrome really has about 30% of complicated cases. Static versus obstruction branch arising from the aortic segment. But again, mesenteric ischemia could have a mortality greater than 35%. When looking at static obstruction, we know that is the result of a fixed obstruction within the dissection of the branch vessel. Dynamic obstruction is the more common, actually, and is the cause of malperfusion of the gut, viscera, as well as the lower extremity. This is an example from our lab of a 54-year-old female. You can see here in A, there's a great example of obstruction of the SMA. Using 3D reconstruction, which we do pretty often, we could see a dissection at the level of the SMA in the suprarenal abdominal aorta. In C, this is an example from our group looking at post-operative covering that area, doing a TVAR just distal to this left subclavian. And then D, you could see how beautifully that there's reperfusion and repressurization of the true lumen in the SMA patent again. Again, one of our cases from the emergency room. This was a 66-year-old man who presented with emergency room with acute onset of chest pain radiating to the back. It was diagnosed, obviously, here, multiple tears, type B, just distal to the left subclavian. And beautifully, a TVAR or stent was placed that showed 1 month follow-up, very favorable aortic remodeling in the far right. So TVAR has been around since 1999. It's getting better every year. We've extrapolated that to EVAR for triple abdominal aortic aneurysm repair. Several clinical trials show TVAR is improved overall mortality than that for medical treatment alone, obviously, and even surgical open retreatment. TVAR reduces false lumen, we know, false lumen thrombosis, and allows the graft to assist in the true lumen expansion. And this is an example of one of our CTs in a sagittal view, a very diffusely ectatic, diffuse calcified and non-calcified plaque, and even a aortic ulcer, you could see. And this is just a beautiful example about literally 24 hours later, using that TVAR and covering the entire area of the descending thoracic aorta. In this amazing publication not too many years ago, they looked preoperatively before discharge and at 5-year follow-up. And at 5-year follow-up, using the stent, you could see significant reabsorption of the intramural hematoma and almost a complete repair of the thoracic aorta. So what about abdominal aortic aneurysms and below the bifurcation of the iliacs? Well, EVAR, we know, has become the gold standard now for AAA repair. I won't go into the detail of when it should be done, but it's just peripheral arterial disease is just growing in the population because our coronary atherosclerosis disease is growing. And as of 2015, there's approximately 3 in 100,000 patients that present with complications and death. I'm just going to skip ahead because I want to show you some imaging. This is great. This is the most crucial, critical components of success with EVAR is fixation, seal, and branch preservation. We know fixation is the active attachment of the graft against the wall of the aorta. The seal is defined as the surface area of contact that facilitates the apposition of the graft to the vessel wall. This has been prominently done for suprarenal, but now obviously we're doing perirenal and juxtarenal and distal renal abdominal aortic aneurysm repairs. And this ERROR EVAR 4 is currently ongoing, and we currently have a lot of patients undergoing this procedure. This is just one of our CTs from this week. This is, again, a patient of Dr. Michael Marin. You can see here, this is a large juxtarenal aneurysm that was repaired. You can see the stent within the bifurcation of the iliacs. It's a large thrombosed aneurysm, but over time, what we follow, we probably do these CTs 3, 6, 9, 12 months, and then annually post-intervention. And what's beautiful, what we look for are any expansion of these aneurysms, particularly that of endoleak. You can see a very impressive endoleak right here in this coronal view. So what do we usually do to look for endoleak and prevent the expansion of the AAAs? Well, we always do a pre-contrast study just to make sure it's not calcification that we're seeing. We give contrast, so you could see here a large abdominal aortic aneurysm that's been repaired with 2 iliac stents. And then we do a post-contrast, which is about 60 to 90 seconds after contrast. And you can see here there is a persistent endoleak, which the surgeon and interventionalists need to know in case they need to put an occluded device in this area of the endoleak, because this would just contribute to the expanding of the aneurysm. Post-contrast CT is more sensitive and specific for endovascular leaks. I'm going to try to skip this video, but this is basically our CT. We start at the chest, the descending thoracic aorta, and we scan all the way down with using contrast, looking at the entire abdominal aortic aneurysm, its bifurcation all the way at least to the femoral arteries. Quickly, MRA, one of my favorites. It's a better contrast resolution compared to CT. We use time of flight. And there's this amazing research publication that we're trying to do here where we use blood oxygenation levels for peripheral arterial disease. It's a T2 weighted image. And basically it looks at calf muscle perfusion. And we could actually measure the oxygenation in the skeletal muscles after ischemic events and revascularization. And we could evaluate the measurements of reactive hyperemia. These are specific sequences that has to be in a skilled MRI expert, but it will diminish and help in with your PAD patients. This is a great example of MRA. It has a higher temporal resolution than that of CT, but you could see here all the way down to the far right in this image that you could see all the way to the tibial arteries, and both posterior tibial arteries are occluded. So again, time of flight, we inject the contrast, we move the scan. The entire aorta from the chest all the way down to the toes is visualized. Thank you.